Hello everyone, I am Dr. P.S. Choudhury, endocrinologist from Kolkata. Today we are going to discuss about the case scenario of a 54-year-old lady with type 2 diabetes mellitus of duration 4 years who presented during routine checkup with generalized weakness. Regarding her past history, she was hospitalized for acute coronary syndrome 1 year ago and she underwent PTCA for that. Regarding her family history, her father had an episode of myocardial infarction and underwent CABG surgery 5 years ago. On examination, her BMI was found to be 29.7 kg per square meter. Her blood pressure was 146 by 86 millimeter of mercury. Her biochemical investigations revealed her HbA1c to be 8.4%. Her LDL cholesterol was 75 mg per deciliter, HDL cholesterol 37 mg per deciliter, and triglyceride was 156 mg per deciliter. Her eGFR was calculated to be 65 ml per minute per 1.73 square meter. Her urinary albumin creatinine ratio was 200 microgram per milligram. Echocardiography revealed mildly dilated left atrium and right atrium. She is presently on metformin 1 gram twice daily, glimepiride 4 mg once daily before breakfast. She is on losartan 50 mg once daily and amlodipine 5 mg once daily for hypertension, atorvastatin 40 mg once a day, metoprolol XR 50 mg once daily, and aspirin 75 mg once a day. She has a sedentary lifestyle and is trying to avoid weight gain and exercises a few times a week. However, she is frustrated that her weight is unchanged and now she reports occasional hypoglycemic events as well. So, what are the important challenges in this patient that are to be considered for management? And these are uncontrolled hyperglycemia, obesity, hypertension, history of previous acute myocardial infarction, microalbuminuria, and occasional hypoglycemic events. Now, if we come to the real-world evidence, then we will find that cardiovascular disease is the leading cause of death in patients with diabetes mellitus. But it is not true that all patients with diabetes have the same risk of developing cardiovascular disease. CV risk increases with duration of diabetes mellitus and is influenced by other comorbidities like hypertension, dyslipidemia, metabolic syndrome, and chronic kidney disease. Moreover, diabetic patients who are having pre-existing cardiovascular disease have the highest risk of subsequent CV events. So, in our patient also, there is a high risk of subsequent cardiovascular event as she had a history of acute coronary syndrome and evidence of multiple target organ damage. Now, according to ADA recommendation 2021, it is recommended that a CV protective agent like SGLT2 inhibitor or GLP-1 analog as a first add-on oral anti-diabetic drug over metformin should be administered in case of type 2 diabetes mellitus patients with atherosclerotic cardiovascular disease. In 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management began with the EMPA-REG outcome study, in which they showed that the primary composite outcome of CV death, myocardial infarction, and stroke occurred less frequently with empagliflozin, and both CV death and all-cause death were reduced with empagliflozin. Not only that, empagliflozin reduced heart failure admissions by 35%. So, this was a major paradigm shift from the previous oral anti-diabetic agents. Moreover, in a sub-analysis from EMPA-REG study, that is EMPA-REG renal, empagliflozin was found to decrease new onset or worsening of nephropathy on the top of RAS blocker therapy, and the addition of empagliflozin was associated with slower progression of kidney disease. This might be attributed to its associated pleiotropic effects, including reduction in blood glucose concentration, arterial stiffness, natriuresis, and decrease in blood pressure and body weight. Now, SGLT2 inhibitor has an added advantage over GLP-1 analog because of its oral route of administration as compared to the injectable route of GLP-1 analog. So if we search for the next oral antidiabetic drug that can be added with empagliflozin, DPP-4 inhibitor can be an attractive option because of its weight neutrality and reduced risk of hypoglycemia. Now, linagliptin, among other DPP-4 inhibitors, has a unique profile with a primarily non-renal but hepatobiliary route of elimination, requiring no dose adjustment in patients with chronic kidney disease. If we look at the Carmelina study, which is a linagliptin CV outcome study, then we will see that linagliptin significantly reduced the progression of albuminuria. However, pioglitazone will not be a good choice here, as pioglitazone will lead to gain in body weight and may lead to fluid retention, increasing the risk of heart failure in this lady. So now, if we return to our case, then we will see that as the lady has uncontrolled hyperglycemia, obesity, previous history of acute coronary syndrome, and microalbuminuria, empagliflozin will be the ideal choice as it will reduce the risk of subsequent CV events, reduce body weight, and delays the progression to macroalbuminuria. Now, the combination of empagliflozin and linagliptin, particularly in this case, offers a suitable component in strategy to achieve a target HbA1c without hypoglycemia and weight gain. Moreover, a reduction in the incidence of genital infections associated with SGLT2 inhibitor has been reported when a DPP-4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. Additionally, empagliflozin-linagliptin combination would reduce the daily pill burden in this patient population, potentially improving adherence to and optimizing the benefits of treatment of diabetes mellitus. Thank you.